welcome back to the show. Today I have a special guest, Dr. Doug Lucas, a double board-certified physician specializing in osteoporosis reversal, hormone replacement, and healthspan. After completing his training at Stanford University and practicing for nearly a decade in the field of orthopedic surgery, Dr. Doug left his practice to pursue an additional fellowship and board certification in anti-aging and regenerative medicine. He went on to achieve the status of fellow in anti-aging and metabolic medicine. This functional and hormone training gave him the knowledge to support his philosophy of patient care and start Optimal Human Health MD, his nationwide telehealth practice. The Optimal Human Health team focuses exclusively on bone health with the mission to educate the world that osteoporosis is reversible. He also launched PEMA BioIdentical after realizing how challenging it was for his patients to find high-quality bioidentical hormone replacement therapy providers. His mission to educate the world plays out on his YouTube channel, The Dr. Doug Show, within his membership community, HealthSpan Nation, and on stages across the globe. Welcome, Dr. Doug.
Thank you. I got to work on that intro. It's a little bit long, isn't it?
No, it's perfect. I always want to know who about the guests on different podcasts. So thank you so much for being here.
Happy to be here.
Yeah. So, ladies, we're going to talk all about bone loss that starts earlier than you think. In perimenopause, we're going to talk about testing and a lot of really great topics. So, listen up, take notes if you need to. So, Dr. Duck, can you tell us what changes start to occur during perimenopause that make women more vulnerable to bone loss, and how early should they start addressing it?
Yeah, so I find in our patients that are in this time frame, right? So women 40s to 50, we see things changing in ways that they wouldn't expect. So the biggest areas are going to be obviously hormonal changes that are occurring. Hormones have a tremendous impact on bone health, and we can really dig into some of the details there. But for women that you're either having, progesterone challenges as their cycles change, or even as the ovaries start producing or stop producing rather as much estradiol, when we see these changes, these fluctuations occur as the cycles get irregular, your bones will start to be affected. There's no question. So everybody's journey is a little bit different there, but those two changes are really common. And then the other thing we see very frequently is low androgen levels. So that would be testosterone, DHEA. And when androgens are low, it removes some of the additional, call it like a backup system, if you will, for your bones. If you don't have that in place, which is also really common as estrogen and progesterone starts to get more dysfunctional, then you really have lost two of the major levers to maintain bone. So that's really common. And then also in conjunction with several of the lifestyle things that sort of occur in this decade for women because of the challenges around, families, career, kids, aging parents, all these things sort of get compounded on this decade for women. And it becomes more challenging to eat the right diet, find the time to exercise, and do all those things. So I think all those things together make this a really challenging time for a woman and her bones.
Yes, I totally agree with that. It's definitely challenging, and a lot of women just don't even realize what's happening behind the scenes. They know that their hormones are off, but they don't really know all of the impact of that, including bone loss. So, what types of tests or screenings do you recommend for evaluating bone health, and when should we typically start doing that?
So most people have heard of the DEXA, right? So most women know that at some point their doctor's going to tell them to get this thing called a DEXA scan, and it's going to tell them if they have osteoporosis. The recommendations as they stand are to screen women at the age of 65. So this is, 25 years from now for your 40-year-old listener, right? But the problem with that is that screening is based off of the principles around public health, meaning that you want to screen at a time in which you're likely to see the disease, which is logical, but not going to protect women from losing bone, right? This tells you if maybe you need a bone drug when you're 65. We'll talk more about those. So from my perspective, I want the people that are looking to optimize their health to consider that bone health is an important part of this equation early on in life. In fact, probably earlier than the audience that we're talking to. Really, it should be early adulthood. But assuming that hasn't happened, let's start now. Let's get screened. DEXA is an okay tool, but it only tells us one of the two important things when it comes to bone strength. It tells us about density. We also need to know about bone quality. So while DEXA is inexpensive, abundantly available, and it provides us some information, there are other screening modalities that can provide us both density and quality. So the one that I like the most, which is not as available, is an ultrasound device called RAMS from the company Ecolite. It's an Italian company that created this software that you can use with an ultrasound probe specifically that they provide. But you can tell bone density and bone quality, and that really helps us in our decision making. And there's no radiation because it's not an X-ray. So it's a really cool tool, and it is becoming more available, but it is not globally available and abundantly available in the US yet.
Okay. That sounds pretty cool.
Yeah.
Yeah. So how often should women be tested for bone density during this stage?
Yeah, it depends on what that first test shows. So if you get that, let's say you're a 40-year-old woman and you're worried about hormones, health span, you say, I'm going to get my, I'm going to get my REMS. Great. If you have fantastic bone, probably don't need to repeat it again in the near future. Maybe give it 2 years, 3 years. You want to see what is changing over time, but you have a lot of room to lose. So you don't necessarily have to keep doing it. If you have osteopenia, though, which is a T score, we'll talk more about that, but the T score is the measure they give you for density. If it's in the osteopenia zone, which means that it's below the average, then you want to consider watching this closely, because while osteopenia may not put you at high risk for fracture, if you're losing bone, this is really important. So I would recommend repeating that on almost an annual basis if you have access to it. If you have osteoporosis, then we need to get aggressive. When we need to start doing a lot of stuff, and then you need to be repeating it because you need to make sure that what you're doing is working. So it really
Right.
depends.
Are there any like blood test markers that you recommend?
Yeah, so there are two markers that we use when we're looking at bone turnover. And there's a bunch of other things we can look at too, like hormone levels and all this stuff. But specific for bones, there's two tests. So one is called a P1NP, and P1NP is a measure for osteoblasts. Those are the cells that are building bone. And then there's the CTX, which is a measure for osteoclasts, the cells that break down bone. So you can actually tell what's happening with your bone metabolism based off of those two markers. But for cycling women, it's really important that we do these under the same circumstances. So, for women that have a measurable cycle, we want to do it on the same day of the cycle under the same circumstances, because hormone fluctuations will absolutely change these biomarkers. So they have to be done under the right circumstances, but they can be really helpful, especially if you're working on improving or maintaining bone, because you can get a sense of what's happening with that balance.
Yeah, that makes sense. So just to kind of backtrack a little bit, what are some of the causes of bone loss or some of the lesser known causes?
Yeah. People think when they hear osteoporosis, we generally think of elderly people. And you can, even if you look in the medical literature, they say primary osteoporosis. And that sort of is synonymous with postmenopausal, meaning loss of estrogen and progesterone as women go through menopause. And while I get all that, there are so many causes of bone loss. And if you think about osteoporosis really as just a bone metabolism issue, meaning that you've been breaking down more than you've been building up for too long, so therefore you have osteoporosis, right? So if you think about all the things that can result in this imbalance of bone metabolism, and the list becomes very long. And so, yes, the absence of hormones certainly is a risk factor for women postmenopause. But hormone dysfunction, hormones that aren't optimized, especially in the perimenopause timeframe, certainly can do it. Dysfunctional ovulation or dysfunctional cycles for premenopausal women, that even going back to early adulthood, can absolutely do it as well. But if you get outside of hormones, diet plays a big role. Inadequate protein, inadequate energy, chronic dieting is a big contributor here. Gut dysfunction, leaky gut, SIBO, all the gut things that can have an impact on food absorption, nutrient absorption. And then you get into like some of the other lifestyle things like chronic stress. Cortisol is really bad for bones. Over-the-counter drugs, prescription drugs, anxiety. I mean, so many things can cause bone loss. And that's part of the problem, is that when people start talking about bones, they sort of get lost because it covers so many things. It's like trying to dip your toe into every single subspecialty in medicine just to talk about one thing, and it gets really confusing really fast.
Yeah. Wow. Yeah, I haven't even thought about all of that. And I imagine most of the listeners aren't thinking of all that either.
Right.
I mean, of course, we talk about hormones and hormone decline and the ramifications of that, but everything else you said, even in terms of a woman's cycle, can affect that.
Yeah.
So just to share one of my a personal thing is I have a prolactinoma. So because my prolactin is elevated and I've done medication, I've done it all to try to get it down. And it's actually not as bad as like a lot of women experience. My estrogen was quite low for a while.
Yeah.
And then of course I was on hormonal birth control for like 13 years, as many women do. So I was just pretty flatlined and
Yeah.
I started to really experience symptoms in my like mid to late 30s. So we will get to hormone replacement therapy in a bit, but just talking about some of the things that you said in terms of causes. So, what are some types of food and lifestyle interventions that women should start to implement?
Yeah. So when we bring people into our program, because our program is all about reversing osteoporosis at this point. So when we bring people in, the first thing we do is we figure out what they're eating. We ask them to track their food, either in a tracker or write it down or just take pictures of it. But I got to know what you're eating. And what we find over pretty much almost every one of our patients is that they're under eating in general, so just not enough calories, and that's come from decades of dieting. And they're not getting adequate protein. So those are the two things we just see across the board. And fortunately, there is a great conversation around protein happening, and people are getting this information out. Like, we don't need to be scared of it, and it's not bad for your kidneys. I was actually just scripting on this right before we hopped on this call. So we shouldn't be afraid of protein for sure, and we absolutely need to get adequate protein. And when I say adequate protein, I aim for in our patients around 1 gram per pound of ideal body weight, or 2.2 per kilogram of ideal body weight per day, which is far above the RDA recommendations. That's not even adequate for some people, though. So that's our starting point. And for some women, we need to go higher than that because they don't absorb it well. And this is much more than most women are getting, and men, actually, for that matter. It's more than most people are getting. So we have to teach them how to get there. And then we also, in doing that, we generally will increase calories. And then we have to talk about, what's the downside of chronic caloric deprivation and what is the impact on the body. But those are the two main things that we do as we turn the corner and we start improving bone health.
Okay. Yeah, I see that as well. I've been coaching women for 12 years now, and I see it over and over. They're just not eating enough, and they're certainly not eating enough protein.
Yeah.
At this stage of life, especially, it's so important to improve that, not just for bone health, but for all the symptoms women tend to experience,
Yeah.
in the stage of life. You've heard me say over and over again how important it is to consume ample protein. As we lose hormones in perimenopause, it is vital to balance our blood sugar and increase lean muscle mass. Protein is one way of doing that, and too many women underconsume this vital macronutrient. While I recommend getting the majority of your protein from whole foods, I'm also a realist and know that life gets busy and sometimes you just need something on the go. Equip Prime Protein is my go-to grass-fed, non-GMO protein powder. Our clients love it, and it comes in a bunch of delicious flavors, or unflavored if you prefer. You can throw it into a shake, mix it with yogurt, make protein pancakes, or whip up a hot beverage. Try it yourself at equipfoods.com/healthcoachclaudia and save 15% with code healthcoachclaudia. So can we move on to exercise? Because that is another one that women, they, like you said, we were chronic dieting for so many years. And then the other thing is like cardio, 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 and cardio is fine. But what else should we be doing?
Yeah, there's value in cardio. So I'm not saying never do cardio, but you're right. I mean, I every time I travel a lot, and every time I go into like a hotel gym, just like it just cracks me up because I walk in and like you got the cardio section, and you have all the women, and then you have the weights, and you have all the men, and I'm
Yeah.
like, what? Like probably like everybody needs to just switch sets,
Yeah.
because like the guys aren't doing enough cardio, and the women aren't doing enough resistance training. And so, yeah, I mean, you're right. So decades and decades of cardio does not make the cardiovascular system that much stronger. We need it. That's great. But we have to do heavy resistance training as the primary thing that we do. And we see this now, again, this conversation of, women being stronger rather than skinnier. Heavy resistance training is going to improve your body composition. It's going to improve your metabolism, your glucose disposal, your hormone optimization. I mean, all of it, right? It's so important. And yet, especially in my population, because most of my patients are postmenopause, they've never lifted a weight in their life. We see this all the time. So we're taking a population of women now that are sarcopenic, they've lost their muscle, they have osteoporosis, and we're teaching them how to lift weights, in their 60s and 70s, which is fun, but it's very slow. So if you're 40, you now have the opportunity to get on this bandwagon and start because it's so much easier to start younger. So now is the right time to do heavy resistance training. And then also, especially if you already have bone loss, doing some kind of impact or simulated impact. And what I mean by impact is literally impact, like jumping off of stuff. So you can do this all the way from like something as simple as a heel drop. This is something that's really easy to learn how to do, all the way to these like assisted pull-ups and dropping off of a bar. Please do this under supervision. But all these things that will cause impact in your body, and your body responds to impact by laying down more bone. And then we can talk about some of the modalities that do that too. But those are the two big things I say we've got to have in the exercise programming.
How often do you think
Yeah.
women should be resistance training?
So I would say at minimum 3 days a week. If you do less, it's a long time in between. So we just need to chronically stimulate the muscle protein synthesis, right? So you have to stimulate each of the major body parts at least once a week. You can do that in 2 days. It just becomes a hard, long workout. You're probably going to miss something. So that's why 3 days is sort of the magic number, because it's basically every other day, right? Um, so I would say 3 days at minimum for heavy resistance training. And then that gives you the window to do, like if you want to do some high intensity, cardio, then great. You can throw that in once a week. You want to do some zone 2, you can do that the other days a week, right? You want to go out and walk 5 miles? Awesome. Go do that. But you got to get that basic framework in place.
Yeah, I agree. I was doing 3 a day, 3 a week, and then for whatever reason, I kind of slowed down. I think the winter, I got a little lazy. But thank you. I'm gonna definitely increase that. You were mentioning just kind of like bouncing up and down. And so kind of like a rebounder be something that
Yeah.
would,
So rebounders are interesting. I get this a lot because I think rebounders are recommended a lot for fall prevention in an older population. And trampolines have a lot of potential value, good for lymph flow and detox. Like we have a trampoline, and like I put my kids out on there because they have crappy genetics for detox. So I'm like, go bounce on the trampoline. So there's value in it, but it's not enough impact to actually cause like the change in the bones that we need. So when I was saying bouncing up and down, I was really referring to like heel drops in general. Like this is a very specific technique where you're literally like dropping your body weight on the ground. And you can, when you do it right, you're like, wow, that's a lot of force. So we have the potential to do these things very easily. We just don't do them.
yeah, exactly. What about like a vibration plate? I feel like I've seen you using one. I have one. I love it, but I want to
Oh,
know,
great.
helpful?
Yeah. So it depends on how it's made. And so the one that I use is from a company called PowerPlate. And I've partnered with them to bring their devices to our audience because there's a lot of different types of vibration plates out there. But if you look at the research on whole body vibration, and just even with just bone mineral density, if you use the right tool, then you can see improvements as just an isolated intervention, which is cool because for those of us that aren't into doing impact every day, which is a lot of people, these things simulate impact. So I said earlier, we can either do impact or we can simulate impact. And this is one way to do that. So I have a power plate. I stand on it at least once a day when I'm home, and I do it in front of a red light. So it's totally passive. I'm standing in front of a full body red light panel, and I'm standing and I'm getting my simulated impact. I'm also, doing all the benefits of red light therapy. So it can do a lot of things that way. And then the other thing I like about it too is if you look at the research on muscle activation and exercising on the device, then there's a whole another world where you can actually start doing some of your workouts on the device using lighter weights, seeing better muscle activation, and it can be a really cool tool that way as well.
Yeah, thank you for that reminder because it is pretty passive for me. I'll just stand on there. Sometimes I'll scroll Instagram. I'm like, yeah, this is
Yeah,
probably not.
which is fine. I mean, it is still doing something for you. So I'll do. I tell my patients 10 minutes a day because that's what the research shows. I personally do because it runs 9-minute intervals. I'll do 9 minutes facing my red light one way, and I'll turn around and do 9 minutes again. And so I'm standing there for essentially 20 minutes, and yes, Instagram happens, or I'm posting actually at the same time.
Right. Yeah. Or listening to a podcast or something. I have my red light here too. So maybe now I'll start turning that on. Usually I do my red light at night for whatever reason, but And then I do the vibration plate in the morning, but I may have to switch up my routine. Okay, so can we shift focus to medications for osteoporosis? Because I hear a lot of people are being prescribed those. My mom was actually, well, they were prescribing it. She didn't want to take it. But what are your thoughts on that? Are they effective?
Yeah, so there's two groups of medications. So most people are put on the what's called the anti-resorptive drugs out of the gate. So these would be your things like Fosamax, Reclast, the bisphosphonate category. Prolia is another popular one in there that's a every 6 month injection. So these anti-resorptive drugs are popular because if I'm a doctor and I have 5 minutes to talk to my patients and they have osteoporosis and I want them to not have a fracture, I need something that I can do quickly. And these drugs are FDA approved for osteoporosis, and they will increase bone mineral density in most people, and they will reduce fracture risk in most people, which is great, except that that's only true in the short term. The problem I have with these drugs is that there's no long-term approach to them if you're using them in somebody who has a, let's say, longer than 10, 15, or 20-year lifespan. So this is really true for people that are listening to you in this perimenopause and early menopause timeframe, because if your doctor says, "Hey, you have osteoporosis, here, take this bisphosphonate," the first thing out of your mouth should be, what do I do in 5 years? What do I do in 10 years? I heard I can only take this drug for 3 years. So what's the long-term plan here, doc? And they usually don't have an answer to that. Or the answer is, well, we'll take a break and then we'll go on another drug and then we'll like this type of drug and we'll add this to that. And it's just like this combination of things that maybe we'll just keep kicking the can down the road. But the problem with that, even that approach, is that these drugs, these anti-resorptive drugs, work by poisoning the osteoclasts, those cells that break down bone. So one way or another, they essentially shut down bone breakdown, which is why you're slowing down bone loss, which is great, maybe. Because the thing is, the bones are these active metabolic organs. So we need breakdown to have buildup. I liken it to like building a road. Everybody's seen a road under construction, right? So they don't just put a new road on top of the old road. They take the old road out and then put a new road in, right? So if you don't have osteoclasts functioning, you can't have osteoblasts functioning. Those are the cells that build bone. So what we see in the bone turnover markers is the CTX will drop down very, very low when you're on these drugs. And then the P1 and P does the same thing. So we essentially have no bone turnover. And what happens over time is that your bones will become more dense because calcification is still happening. Your bones will become more dense, but they become brittle because they lose their strength. So you get dense, weak bones, which will increase fracture risk eventually. That's why you can't take these drugs forever. So if a woman is, let's say, 80, 85, 90, and she has a 10-year life expectancy and she's rapidly losing bone for whatever reason, this might be a viable choice. But if she's 50, 45, 40, and her doctor says, let's put you on this bisphosphonate drug, it's really going to help your bone density, that's a red flag for me that we need to look and figure out why she's losing bone. Let's work on reversing those causes of bone loss. Let's optimize this woman before we put her on a drug that has a limited lifespan and is potentially going to negatively impact her bone turnover for a long time. So that's why I don't like those drugs. And the patients are onto this too, because those drugs have an 80% failure rate, meaning that people don't take them. They don't want to take these drugs.
Yeah, that's what I'm hearing. But that's why we have guests like you on to give us, the information that women just really aren't getting. People in general aren't getting. So if somebody is not going to take a medication or want to go that route, let's talk about hormone replacement therapy because, is that something, one, can that be used in conjunction with those medications, or are you more of a fan of using them instead of?
Yeah, so it's interesting. Because we do a lot of HRT, I get patients that come back to me and they say, well, my doctor wants me to take this bone health drug and I want to do it. But they say that I have to come off of the HRT to do it, which is like just melts my mind when I hear these comments, because the studies will the studies show, this is the way they interpreted the data. The studies show that if you're on HRT, the drugs don't have as much impact, which is true, except that these drugs only work if you have rapid bone loss to begin with. What happens when a woman is on optimized HRT? she's not losing bone. So the drugs aren't going to be as impactful because she doesn't need them anymore.
Wow.
Right. So it just depends on how you look at it. Right. So what my response is, look, you get to choose what you want to do with this other provider. But I will tell you that with optimized HRT, we can outperform bone health drugs hands down. And the literature supports that. The nice thing too about HRT is that it's going to help with a whole bunch of other stuff, doesn't have the negative side effects and risks of the bone health drugs, and you can do it for the long term. So why not optimize this tool first? Now, not all women can be on HRT, and that's okay. Like there are other options, but if this is an option, it really should be considered.
Yeah, and I would venture to say that it's an option for most people, even they may not be aware of that. They may not even, a lot of them just don't have the education. A lot of them just aren't being offered it. They're not going to the right doctors for it, which is obviously a big part of what I try to educate women on how to find providers who are going to prescribe and who know what they're doing.
Yeah,
That's another
really
key.
hard. Yeah.
So when it comes to HRT, I've watched some of your YouTube videos in regards to like dosing. We don't have to get into all the details of that, but it seems like there's a lot of providers out there, and women hear this too, and they get it in their heads that you have to be on a low dose regimen. I mean, I'm somebody, like I said earlier, I mean, I started in my, I guess it was like my late 30s with hormone replacement therapy. And I just I've been having to increase because of absorption issues, not feeling like 100%. I'm like, I know I could feel better. And because I want to make sure that I'm protecting everything, including my
Right.
bone as I get older.
Right.
So, can you speak on that a little bit?
Yeah, so we've had a great journey here. So early on, we recognized, I mean, immediately out of the gate, like, okay, hormones are important, right? But we didn't know how important. Also, I was even trained on hormones in sort of like the functional medicine space. I was trained to use, these alternative ideas to begin with. So I was never a, commercial patch synthetic progestin, like hormone replacement guy. Like that was never my thing. I would never prescribe birth control, not once in my life, and nor will I. But even in that paradigm, even in this sort of like new age paradigm of functional integrative medicine, I was still trained to use low dose estradiol or biased, let's make it worse, low dose biased 80/20 estriol estradiol, right? Like I was still trained to be scared of estradiol. So I really had to go through this education process, and there's nothing like writing a book to really educate yourself on a topic. So I wrote a book on hormones, and in doing that, I was exposed to so much because I dedicated the time to doing the research, talking to experts, and I was like, oh my gosh, like I thought I knew something about hormone. I knew nothing about hormones. So it totally changed the way that we look at things. So now what I love about where we are with hormones and bone health is that we have the ultimate tool to tell you that your hormones are optimized. And everybody can use this. We just happen to be using it because we are treating bone health. So the bones are amazing because they tell you what's going on with your hormones. So you have the bone turnover markers, like I said, but if you pair those then with other blood markers of estradiol, FSH, then you can get a sense of what's happening on the cellular level. Because we know that we're not going to optimize CTX and P1 and P until your estradiol levels are optimized. So now we can look at CTX, P1 and P, estradiol, and FSH, and we can get a sense of what's happening in the brain, what's happening in the bones, and then probably what's happening elsewhere in the body. The heart doesn't give us good biomarkers, but the brain tells us FSH, the bones tell us CTX and P1 and P. So now we don't even have to use arbitrary numbers. Now we can actually dial it in and then see what's happening with the rest of the biomarkers. And then, of course, asking about signs and symptoms. When we do that, it's amazing is that I can tell you there isn't a threshold that everybody should be aiming for with estradiol. The literature supports around 60 to 80 picogram per ml. But there are some women that do great. Their markers look great at 20 to 40, right? They are on actually a pretty low dose. And then other women need, 100, 120, 150. Some women are not from me, but from other providers have, estradiol levels 300, 400, and that's what it takes for them to be optimized. So I think that we don't understand what's happening on the cellular level. So it really takes an inquisitive mind and working with different dosages, strengths, even routes potentially to try to optimize these things.
Yeah. Okay. I love that because I always say to all my clients and just anybody who listens, like we're all unique, and what works for one person may not work for somebody else. And finding somebody who's going to optimize your regimen, your dose, your application is really important. I mean, I've used a patch, I've used creams, I use sprays, and I feel like I'm still not optimized. I mean, I feel much better, but I think, I'm just very trying different things to just make sure that I'm feeling good. All right. So the last thing I want to ask you is about supplements because the online space, as you know, is just crazy. There's so many people who are just giving these blanket recommendations. I don't like that. I like testing. But I'm curious what your take is on the specific, the ones that are really touted for bone health, like calcium, vitamin D, magnesium. Can you give us a little bit of insight into that and what your approach is for supplementation?
Yeah. So the big picture here is you're probably not going to supplement your way out of bone health problems because the reason why you got there wasn't a supplement deficiency. So we do use supplements. I think they are valuable in this space, but I think they're over talked about. People overestimate what the impact and value of these things are. But we recognize that for most people to get here, they need to have had deficiencies, and it's easy to correct some of these deficiencies with supplementation. So we definitely use them. All of our patients are on a pretty extensive supplement stack because they're coming at this from a position of being deficient. If you look at the traditional recommendations, calcium and vitamin D, osteoporosis is not a calcium deficiency problem for most people, right? So it's pretty easy to get enough calcium in our diet, especially if you consume dairy. So generally, we're not deficient of calcium. So just taking calcium by itself, I don't love that. There's also some interesting data to say that if you were to just take calcium without vitamin D, which I hope nobody's doing, but if you do that, you actually do see an increased risk of calcification of arteries, specifically your coronary arteries in your heart, and an increased risk of heart attack and stroke. So calcium actually could be dangerous. And I think this is becoming pretty well known. The good news is even if you're taking a crappy calcium like calcium carbonate or citrate, and you add even a little bit of vitamin D, that risk seems to go away. But I think we should take it a step further and say, okay, let's talk about these recommendations of 1,200 milligrams of calcium for women. This is over the age of 65 and 1,000 for under. That's a lot of calcium, especially to come from a synthetic source like a citrate or carbonate, which is like chalk, right? It's like the same chalk that your kids use to draw on the sidewalk. So this isn't a great form of calcium. It's not well absorbed. Your body doesn't know what to do with 1,000 or even 500 milligrams at one time. It's not how we're designed to consume food. So if we're going to get calcium, it needs to come through food or whole food sources and supplementation. And that could be like ground up bones, could be algae forms of calcium. I think all of them are going to be absorbed better, utilized better, and then add in the vitamin D, the vitamin K, the magnesium, like all the other things that you need to go along with it. And that's why when you see the bone health products that are made by good companies, they have all those things in there together, including some other cool things that can help build bone. So I think there's definitely a role for that. But we almost look at it more like, let's look at the big picture and see what you need. We use biomarkers as well. But we're also talking about muscle things like, essential amino acid complexes. We're talking about like collagen and creatine and magnesium. And we create a foundational stack, and then we add some of the special bone health stuff on top of that.
Okay. Yeah, I love that. I say that to clients a lot because some of them will be taking, like maybe even a doctor may have said to them, oh, you should be taking calcium, and they'll be taking these high doses. And we're like,
Right. Just taking like a
I don't want to ever.
capsule full of chalk.
Yeah, I mean, I don't like to be a fear monger, but I'm just like, well, let's not do that. Let's see what's going on here. Especially if somebody's coming to us and they have like all this pain. We're like, oh, that's probably not a good thing. Calcium maybe is not going where it needs to be. But yeah, I love that. And yeah, we need those cofactors to really support our body. So anyway, thank you. That was really, really informative. Where can listeners find you?
Yeah, so we put a lot of time and energy into our YouTube channel. So if you look, the Dr. Doug Show is what it's called, but just look up Doug Lucas on YouTube, you'll find our channel. And it's called the Dr. Doug Show, Bones, Hormones, and Healthspan. So that's where all of our free content is. I do 3 to 4 videos every week, and it's just a ton of stuff. So great community on there, great place to start if you have questions about bone health. Beyond that, we have the companies that we've started to help support women and men, but mostly women, in this process. So the hormone company specifically is called PEMA BioIdentical. And it's okay that you said that wrong because everybody says it wrong.
Sure.
So yeah, that's actually my daughter's name is Pema, and we changed it the day that she was born because we wrote PEMA which is what the name of the company is. And every nurse in the hospital said PEMA. And so we very quickly said PEMMA. And so now it's Emma with a P, it's PEMA. But anyway, PEMA means Lotus, and the company originally was going to be called Lotus BioIdentical. So that's how we got there. So PEMA BioIdentical is the company, nationwide telehealth and health optimization through the way that we just described it. We have our bone health community, which is called the Osteo Collective, and we'll make sure everybody has these links. The Osteo Collective is again, community, people DIY in bone health, tons of resources, live Q&A every week with myself or a team member. And it's a great way to find out more information, ask questions about it. And then lastly, our Optimal Human Health program, which is our comprehensive membership style where, if you have a problem and you're still losing bone and you want to figure it out, we're the ones to help you do that. So that's at Optimal Human Health. And that's I think it's a one-of-a-kind program. It's amazing if that's what somebody needs.
Yeah, sounds amazing. I'm so glad that you have all these resources. I love your YouTube channel. Like I said, I was binging some of the videos. It's just a really great place to get really solid information. So thank you. Thank you for being here. Thank you for all you do. And we will put all those links in the show notes. And that's it. All right. That's a wrap. Until next time.
Thanks, everybody.
Hey, before you go, if you're resonating with this podcast and realize that your symptoms are anything but normal, my comprehensive program, the Perimenopause Method, may be a great fit for you. My team and I help women in their mid-30s to early 50s improve symptoms such as fatigue, disrupted sleep, anxiety, erratic moods, bloating, and much more. We do this by utilizing advanced testing, a personalized plan tailored to you, women's health and hormones education, and ongoing support so you never feel alone and you get results. If you're ready to commit to your health and feel like yourself again, but even better, check out the link in the show notes to learn more about the Perimenopause Method. The information provided is for educational and informational purposes only. I am not, nor do I act as a doctor or any other medical professional. I am not providing healthcare, medical services, or attempting to diagnose, treat, prevent, or cure any physical, mental, or emotional disease or condition. The information shared is not intended to be a substitute for the professional medical advice provided by your own medical or mental health provider.